Assalamu alaikum. The clinical day, starting with the first scenario, Mr. Smith, 50 years old, came with complaint of dyspnea. His blood pressure 140/90, pulse rate is 100, temperature 37.5, saturation is 95. So you're ready, Dr. Ryan? We can start. Dr. Tanvir?
Yes.
Yes, I'm ready.
Okay, here you go.
Hello, my name is Dr. Ahmed. I'm one of the doctors in the clinic. May I confirm that you are Mr. Smith, 50 years old?
Yes, doctor.
Nice to meet you, Mr. Smith. I am here to ask you some questions about your health condition. I will examine you and answer your concerns. Is that okay with you?
It's okay, doctor.
Can you please tell me how can I help you today?
Yes, doctor. Actually, you know that last 1 week I feel my breathing difficulty, and also I feel some tiredness, and I feel that my body temperature increased. So I am worried actually what happened with me.
I'm sorry for your suffering, Mr. Smith. I'll try my best to help you. Do you need any painkiller at the moment?
But it's okay, doctor.
So, Mr. Smith, before this 1 week, were you completely normal?
Yes, before I think it was okay. I'm okay.
You were okay.
Yes.
Okay. Can you tell me more about the shortness of breath? Started 1 week. Was it sudden or gradual in onset?
I feel that initially it was a little not too much bothering, but nowadays I feel it's more.
Okay. And do you feel the shortness of breath while walking, while doing some exercise, or even at rest?
No, initially when I'm walking, but nowadays even I take rest, I feel also difficult to breathe.
Mm-hmm. And do you feel difficulty of breathing when you lie down?
Yes,
Okay. And have you ever woke up from sleep searching for air?
yes, sometimes I'm feeling difficulty during sleeping time.
Okay. And how many pillows do you use at night?
I'm trying to compensate it by using two pillow.
Okay. Uh, have you noticed anything worsening this shortness of breath
Yes,
apart from?
nowadays I feel that when I'm doing something work or when I'm walking or jogging, I feel not too good.
Mhm. And have you noticed anything that improves it? For example, are you using any medications, inhalers?
No, I am not feeling any medication helping me.
Okay. Do you have any cough or coughing of blood with that?
Yes, I feel coughing, but not blood cough.
Okay. Is the cough dry or wet?
I feel there is something phlegm coming with that cough.
What's the color of the phlegm?
It's mostly white color, not blood mixed.
What is it? Sorry?
Not blood mixed, normal color.
Normal color. Okay. Any chest pain?
Yes, doctor, I feel also some chest pain in my central chest area.
Mhm. Can you describe it for me? Like, is it like
Yes,
a
doctor,
crushing,
I feel there is some dull pain.
dull pain? Okay. And does it go anywhere else from your center? Does it go to your left side, left hand, or jaw, or neck, or back
No,
of
I
the
don't
chest?
feel.
So it's only in the center, not moving even to the back.
No, it's not.
Okay. And when did you get this chest pain? Is it also with the shortness of breath 1 week ago?
Yes, I feel almost the same time.
Okay. And is this chest pain relieved with sitting forward, for example, or no? Or have you noticed
No,
anything
it's
improves it?
not like that.
Have you noticed anything improves it?
No, I don't feel any improvement factors.
Anything worse than this pain?
Yes, as I said you, that pain actually not too much. I feel breathing difficulty both, but also associated mild pain.
Okay. Uh, oh, okay. And any awareness of heartbeat?
Yes, and sometimes I feel that my heartbeat increasing.
Mm-hmm. Okay. And is it regular or irregular? Can you tell? Can you tab it for me?
Yes, yes, it's regular.
Okay. And do you have any noisy breathing?
Not like that.
Mm-hmm. Have you noticed any leg swelling or any swelling in any part of your body?
Yes, doctor, I feel also my leg is little swelled than before.
Mm-hmm. Okay. Does it leave a mark if you sit on it for a long time or you wear your socks?
I feel there is a little mark when I press it.
Okay. Do you have any past medical history I should be aware of?
Yes, doctor, actually last 2 weeks back I got road accident and doctor said there is a one bones of
You,
my leg fracture.
Dr. Tanvir, I cannot really hear you properly.
Okay, you are
I didn't
listening
hear.
now?
Yeah,
You are
please
listening?
adjust the mic, Dr. Tanvir. We can hear, but there's some change in the sound. I don't know, it's muffled or...
It's okay now?
Yeah, okay, clear now.
Okay, actually, doctor, like you know that like 10 days or 12 days back, I got a road accident and there is a fracture happened in my leg. And I was admitted in the hospital. They are giving some antibiotic. Like they said that they need to give more antibiotic to my children, IV children.
Okay. Fracture in your leg.
Yes,
And you got antibiotics already and you were discharged. Is it right?
yes. I think they gave me like they admit me 1 week or 8 days. And they give me every day antibiotic.
Okay. Apart from this, do you have any other past medical history I should be aware of?
Yes, doctor, I have also high blood pressure, and in my childhood, I heard that there is a something my heart disease something, but I'm not sure actually what. But for the blood pressure, I'm taking medication.
Mm-hmm. Okay. And any other health problems?
No, doctor.
Any surgeries or procedures?
No, as I said you that they did surgery for my leg and give antibiotic.
Okay. And can you show me your medication list?
Yes, I'm taking lisinopril 5 mg and also taking no painkiller, diclofenac.
Mm-hmm. How often are you taking the diclofenac?
Because after the surgery, I'm taking like last 10 days I'm taking.
Most of the days?
Yes, most of the day because I have pain there.
Okay. And any recent change in the doses?
No, 2 times I'm
Okay.
taking.
Okay. Okay. Apart from this, you told me you have raised body temperature. Is it for the this week as well?
Yes, doctor, this week.
Okay. And have you measured it?
Yes, doctor, it's like 37.5, 38, like that.
Does it have a specific pattern or is it all the time there?
Most of the time I feel feverish.
Okay. Any sweating or chills?
No,
Any weight changes?
no,
Any lumps or bumps in any part of the body?
no,
Any weather preferences?
no,
Anyone commented that you are paler than before?
no, not like that.
Okay. Any headache?
Yes, there is fever, I feel little headache, but it's not too much something serious.
Mm-hmm. Any vision problem?
No,
Okay. And any weakness in any part of the body?
no,
Any abnormal feeling, abnormal sensation?
no,
Any joint pain?
no.
Any skin rash or skin rash on sun exposure?
Yes, doctor, I feel there is some skin rash in my hand. I'm also worried about that.
Skin rash in your hand. Can you show me?
Yes, I will send the picture.
Okay.
You
When
can
did you
talk,
get
you
this
can talk.
rash? When did you get this
I
rash?
feel also like this 1 week.
1 week. Okay. Is it itchy? Is it painful?
I feel there is a mild pain, but not itching.
Okay. Any discharge or any bleeding?
No, not like discharge.
Mm-hmm. Okay. Okay. Apart from this, any rash anywhere else?
No.
Okay. And do you have any tummy pain or tummy bloating?
I feel some discomfort in my tummy in the left side.
In the left side.
Yes.
Okay. Since when?
Last 1 week.
Okay. And do you know the nature of this pain? Can you tell me?
I
Is it a
feel like
crampy pain?
compressing type pain. Compressing type pain.
Okay.
Discomfort actually, mainly discomfort, not like pain, discomfort pain.
Mm-hmm. And on a scale from 1 to 10, so not pain.
Not pain, mainly I feel discomfort, some pressure.
Have you noticed anything worse in this discomfort?
No, there is no factor like that.
Okay. Any change in your bowel habits? Loose motion, hard
No,
stool, or change in the color?
no, it's okay.
Okay. Any change in your waterworks or frothiness or blood?
I feel there is some blood is coming with my urine.
Blood in your urine. Okay. Since when?
It's also like 1 week.
Mm-hmm. Any burning in the urine?
No, not.
Okay. Any frothiness?
No.
Okay. Is it the first time to have this problem in the urine?
Yes, first time.
Okay. With regards to your heart problem in childhood, have you seen any doctor, any investigations?
Actually, they said this mostly actually no need treatment now. It's mostly it will be solved. They are not giving it too much something seriousness.
Okay. Okay. And can I ask you some personal questions?
Somebody I think need to be mute. Overlapping. Yes, yes, doctor.
Do you smoke?
Sometimes, not regular.
So I advise you to stop smoking as it's dangerous to your life. Uh, do you take alcohol?
It's occasionally.
Mm-hmm. Okay. And what do you do for a living?
I'm teacher, doctor.
Okay. And how is this problem affecting your life?
Yes, doctor. Now breathing problem and also fever. I am actually cannot do my work properly.
Okay. I'm sorry for your suffering. I'll try my best to help you. And do you have any partners?
Yes, I have regular partner. I have wife.
I'm sorry to ask you, any casual relationships?
No,
Okay. I'm sorry to ask you again, any sharing of needles or party drugs?
no,
Okay.
no,
Any sick contact recently?
no,
Any history of travel?
no.
Can I examine you?
Yes, sure.
Okay, I would like to start with the hands. Okay. So, any joint swelling, any nail changes
You
in the
saw
hands?
there is some skin changes in the hand. I already shared the picture.
Yeah, I saw the picture. Okay. Is it
Yes.
blanchable? This redness, is it blanchable? Is it
Not
raised?
blanchable. Not
Okay.
blanchable. In the finger, it's little raised.
Okay. In the finger, raised. Okay.
Yes.
What about the pulses? Are the pulses normal
Pulse
in both?
regular.
Mhm.
Pulse regular, 100 beat. I already shared in the group the vital sign.
I mean pulse is not feeble in any side, huh?
No, it's
Strong.
okay. Normal pulse rate, normal volume, 100 beat, and no irregularity. Regular.
Okay.
The
Then
Latif?
any JVP, raised JVP?
No,
Okay. Any conjunctival pallor, scleral icterus?
no,
Any mouth soreness, central cyanosis?
no.
Okay. I want to examine the chest. Any heart murmurs?
2 minutes left. I will add
Pulp.
1 minute for you, okay? 2 minutes from now.
Yes, you will find there is some systolic murmur in my left side.
Systolic murmur where?
In the left side.
In the left side. Okay.
Yes.
Okay. Any extenuation of this murmur, like with taking a deep breath in and out? Where is the location of the murmur exactly?
Mainly in the apex area.
Any radiation to the axilla?
Yes, if you check, you can find there is a radiation.
Okay. Then any basal crepitations?
Yes, there is some coarse repetition.
Okay. I want to check for palpable B2, parasternal heave, and point of maximal impulse.
It's okay. Pulmonary hypertension feature negative.
Negative?
Negative pulmonary hypertension.
Okay. I want to check abdomen, any tenderness, organomegaly, and the site of the discomfort in the left side.
We found there's in the left side, there is some spleen is like one finger breadth enlarged.
There is what? Sorry, I cannot hear you, doctor.
Spleen.
Spleen is
Spleen is
palpable.
one, yeah, yes, one finger breadth below the costal margin.
Okay. Any leg swelling?
Yes, as I said, you might be edema.
Okay. So, Mr. Smith, what is your concern?
Yes, doctor, I want to know actually what happened with me.
I highly appreciate your concern, Mr. Smith. Actually, I'm not quite sure. I have a few possibilities in mind. Of these possibilities could be related to the recent fracture that you had. Other possibilities could be infection in the lining of your heart. So we need to run some blood tests. We need to admit you. We need to run some blood tests and do some scans and involve a group of doctors. And we will manage you accordingly.
So, doctor, this fracture, how making that breathing problem? What is the relation of fracture with breathing problem?
Yes, I highly appreciate your concern. Sometimes with fracture, there is something called fat emboli, in which some part of this, after the fracture will hit your subcutaneous fat, that is the fat under your skin, and it can go to other parts of the body, leading to this shortness of breath and this heart failure. Are you getting me? This is one of the
Okay, doctor.
possibilities only. Other possibility, as I told you, is an infection in
Okay,
the
doctor.
opening of your heart.
Okay, doctor. Thank you.
Thank you. Dr. Tanvir, what is this case?
Time finished?
Your cases are very okay. Yeah, ask me. I don't
Okay.
know. I
Okay,
don't know.
examiner question. You can guess. You
Don't
start now.
check
Examiner question.
don't check the chart. Don't check the chart.
No, I'm not checking anything. I really
Okay,
don't know what's this.
Okay, I
Okay?
think better in the chart not to write before finishing that.
Don't
Bye
worry.
bye.
I'm not
Okay.
reading.
No. Okay,
Okay,
anyway,
start
so
presentation now. Start presentation.
what's your presentation and what's your differential diagnosis?
So I examined Mr. Smith, 50 years old male, presenting with نسيت the presentation. Presenting with dyspnea for 1 week, along with low-grade fever and skin rash. Had history of a fracture 1 week back, for which he was started on antibiotics and discharged home. He's coming with symptoms of heart failure along with rash. And on examination, I could find like a reddish, erythematous rash in the fingers, bilateral. And he has low-grade fever, he has tachycardia, and he has a systolic murmur in the mitral area, radiating to the axilla, with splenomegaly and lower limb swelling. He also has basic crepitation. So,
Okay, so what's your main differential diagnosis?
my main differential diagnosis could be infective endocarditis. I think so.
And any other?
Other differential, I was thinking fat embolism after the fracture. But against that, there was no really good chest pain.
Okay. So, what are you thinking that cause of this infective endocarditis? You think this is infective endocarditis?
I was thinking because he already has an underlying heart condition and he had a recent surgery. So maybe that is a reason for infective endocarditis. That is a trigger.
Okay. So how will you investigate this case?
Investigation, basic investigations, full blood count with differential and ESR, CRP, renal function panel, liver function panel, and electrolytes, and 3 sets of blood cultures from different sites, urine microscopy, and the ECG, echo, chest X-ray, septic screen, like full septic screen, respiratory panel, pneumonia panel.
Okay, what is the criteria of the
urine,
infective endocarditis?
urine analysis with culture. Sorry?
Criteria of the diagnosis of the infective
Criteria,
endocarditis.
major criteria and minor criteria. Major criteria, positive blood culture for the organisms and the typical organism, and the echocardiographic finding of vegetation or like new murmur. The minor criteria, immunological phenomena, and what is it called? Vascular phenomena, positive blood culture for other organisms that are not meeting the typical ones.
Okay. How will treat this case?
Treatment, multidisciplinary team approach, disease education and counseling, and involvement of cardiologists, smoking cessation, then treatment of the underlying cause with IV antibiotics, empirical IV antibiotics, analgesia, until we get the culture, then we can specify what antibiotic exactly. I think that's it. Then we can look for criteria for like surgical intervention if proved to be infective endocarditis.
Okay. My last question. If infective endocarditis is not improved, like what are the criteria for surgery for infective endocarditis?
Criteria for surgery. PR prolongation suggesting abscess formation, persistent fever, persistent positive culture despite appropriate antibiotic, and septic emboli, like multiple septic emboli, with a large vegetation more than 10 millimeter, I think. Positive culture for organism like Staph aureus or fungal infection. I forgot what else.
Okay, thank you. 5 minutes finish. Bye.
Why is your case very complicated, yeah, Dr. Tanvir?
I
Be a
think
little
it's
bit gentle.
not complicated. It's not
You know,
a complicated. And you catched.
yeah,
It's
yeah.
not.
Thank you, Dr. Viri. It's a nice
Every now,
case.
yeah, Dr.
See,
Basim,
if it's
every
give
question I
very,
ask, he
I
will
will
say
tell
yes.
you, Dr. Ryan, I will tell you, Dr. Tanvir make the level of hard level of the game. You know,
if I
so
give
yeah,
very
he's
simple,
preparing you for the
no
exam.
benefit.
He's preparing you for the exam cases.
Wallahi,
Exactly.
he is making me scared, wallahi. Allah yastur.
No,
But
no. It's a
mashallah,
very clean cut.
yeah,
It's
you
a very
mashallah
clean
were
cut.
you were calm till the end. Although you extend the time, or you exceed the time, but still you can catch some finding.
Wallahi, okay, inshallah khair. Dr.
I,
Let's
Tanvir,
let's hear Dr.
okay.
Tanvir comment. Yeah, go ahead.
I give some comment. I give some comments. First of all, Dr. Ryan did very nice, very well performed. And I actually not making it much complicated. I give some very typical finding of the infective endocarditis, all the typical finding. Okay,
but you made
and
it
you
very
catch
short history. That's why. I mean, 1 week, I
very
thought it's
short.
very short. Yeah.
No, infective endocarditis is not like that. 1 month history he will come with you. Infective endocarditis
Okay.
is something serious and acute condition, and you have to treat
Yes.
acutely because it can causes multiple systemic effects. Anyway,
Mm-hmm.
you did it very nicely, and yes, I give good background history and finding. Like this patient, first of all, this patient has something childhood heart disease. I mean something valvular heart disease, but he
Mm-hmm.
is not sure. You mean that some small VSD? If a small VSD, actually most of them, if asymptomatic, it's no need of surgery. Small VSD,
Mm-hmm.
lots of people have a small VSD. They have persistent murmur, like not much significant. And until hemodynamics are unstable, they are not going for surgery. If there is a normal lifestyle, no cyanosis, no other complication. So that is the one issue, one clue. So any congenital heart disease is one of the risk factors of developing of infective endocarditis. Second thing is, I said I have high blood pressure. You did not ask my family history, I think. That is there any family history of a similar condition or other condition? If you ask me,
Yeah, I
I will,
forgot. Mm-hmm.
yes, I will tell also my father has some heart disease like that. I will tell like that.
Mm.
Okay. Second thing is I am taking lisinopril. So, and now patient last 2 week or 10 days back, he got road accident. This is important clue. And I said you that he is taking too much IV antibiotics. So who are IV drug user or IV antibiotic? I mean IV channel overusing something. This is one of the risk factors of developing of the infective endocarditis. In
No,
the majority,
I didn't get that, Dr. Tanvir. Can you repeat? IV drug
yes,
use or IV
IV,
No,
antibiotics?
IV
no, the
driver,
line.
even IV
Yeah, the
line,
V
IV
line.
channel,
Yes.
IV medicine, IV drug, recreational, anything. Overusing, this is another risk factor for developing infective endocarditis. If you go for what are the risk factor, like it can develop normal heart, the prosthetic heart, congenital heart disease, and IV drug user. So these are the risk factor. Okay.
But
Then
this IV antibiotic is a medical, so it should be
yes,
cleaned. Is it a risk factor? I did.
we don't know that it's clean because cannula infection can develop because
Still,
there is the one
yes.
important thing. Who
Still
is
risk
using
factor,
cannula?
Dr. Yes, exactly.
Yes. Who has the cannula? You have must check that cannula is clean or not because this is very important. Because if cannula not regularly changing, not regularly cleaning, then it can develop that any cannula induced infection. Okay. Then patient came here with the road accident, high blood pressure history, and also childhood heart disease and road accident, IV channel using. Now patient develop what? The granulation and ocular nodes. They have granulation and ocular node in the picture is showing. BP is borderline high, temperature little high, pulse rate is borderline tachycardia, and also
Mm.
SpO2 is borderline low. And patient came here, yes, patient said, yes, there is a no visual disturbance, but you need to check that fundoscopy, Roth spot, because Roth spot is another finding for immunological finding for infective endocarditis. Then
Mm.
you go downside in the mouth, no ulceration, you check heart, yes, there is a murmur, and it's related to the apical area. So MR is one of the finding because if you are go for echocardiography for infective endocarditis, there is a one finding is MR. Okay, then you found there is a bilateral chest crackles. So if there is a crackles, you should ask cuffing because by
Mm.
cuffing exchange or not
Mm.
ruled out. Okay, so and breast sound is normal, and you go for abdominal tenderness, you found that is splenomegaly, slight splenomegaly. So this is another feature and patient has hematuria. That is another feature and patient develop leg edema. So leg edema is due to the heart failure because infective endocarditis can cause heart failure and mitral regurgitation. So there is a
Mm.
pitting edema. In the hand, you already found ocular granulation. You need to check any splinter hemorrhage. You need to check the pulse, any tachycardia or irregularity, I mean, any atrial fibrillation or not. And the infective endocarditis actually can cause a multi-systemic disorder, even renal failure, even its effect over the brain and the multiple organ, lungs, brain, heart, everywhere it can affect. And you did the investigation, yes, all the basic investigation, ECG, echocardiography, blood culture, and all other basic investigations. So one major criteria, two major criteria, or one major, three minor criteria, and five minor criteria. Under the minor criteria, you said already vascular and immunological phenomenon, high fever, these are the end. You have to start, first of all, that you have to start the antibiotic. This is very important. Patient education, counseling, admission, social occupational support, and also cardiologist, infective doctor, infectious control unit. You need to start the antibiotic. There is some empirical antibiotic. There is some prosthetic valve antibiotic. There is some staphylococcus related antibiotic. But mostly this patient, you need to give flucloxacillin or vancomycin, because mostly these cases I made it like due to the IV channel use. So IV channel used mainly staphylococcus aureus. So you have to go for this mainly the flucloxacillin or vancomycin. And there is another two question can arise. You mentioned already what are the criteria for the surgery, and another thing is in which cases you will give that prophylaxis for infective endocarditis. And your DD, it can be infective endocarditis, can heart failure, can pneumonia. So this your basic need. I think that's all from my side. Thank you. You
Excuse me,
did
what
very
will
well.
be the DD?
Thank
What
you.
will
Thank
be the
you.
DD?
Like
Sorry?
it's infective endocarditis, even pneumonia. You can tell pneumonia here, and also heart failure, acute heart failure, like that.
Yeah, thank you, Dr.
And what
Tanvir.
will be the prophylaxis? What will be the prophylaxis?
Prophylaxis?
Prophylaxis.
In which condition we will do the prophylaxis?
In the prophylaxis, actually, like you know that common procedure. Usually not using the prophylaxis, but if somebody have previous history of the infective endocarditis or unrepaired congenital heart disease, and I think there is some criteria. I forget.
Yes.
Two, three, I remember.
Prosthetic valve
As
Unrepaired,
uh,
prosthetic valve, unrepaired,
and
previous
cardiac
history of the
transplant.
infective endocarditis, and
yes, Dr.
cardiothoracic
Basam is right.
transplantation.
Yes.
Yes,
Heart
Yes.
Dr.
transplant.
Basam is right. Yes.
Yeah, they are
Go on.
four. Heart transplant, congenital heart disease, are either
This is
corrected partially or
unrepaired.
exact.
Yes.
Unrepaired.
Repaired or unrepaired or partially treated. And
No, if
the
it's repaired, it's another issue. If completely repaired and no residual effect,
yeah,
so that
if
is not indication
partially.
actually.
So let's say partially, yes. And the
Yes,
previous infective endocarditis and prosthetic valve. These are the
prosthetic
indications
valve.
for yeah for
Yes.
Yes,
antibiotics.
exactly.
Yeah, thank you, Dr. V. Very nice case and very common. I don't know why, Dr. Ryan, you give the patient suspicion of the cholesterol or fat embolism while you have something is
Actually,
common.
yeah, you
It's
are
okay.
right.
It's yeah. Better to give the common to the patient, not
Yes,
the very
yes.
less common. Why? Because you will take long to explain what is the cholesterol or fat embolism. Very difficult to explain it.
Mm.
Either
Yes,
to give something common, and while giving differential to the patient, to the examiner, sorry, you can say whatever you want to say.
mm-hmm.
But you did great, really. You were calm till the end. Although you didn't catch it, but still you are calm. And this is good, by the way. The stress in the exam will make you more stressed and you will be more panic. You forget everything. But mashallah, you stay calm till the end. You ask all the question except family history, the surgery, and every social point you ask for, also the occupational, the smoking, the job. I don't know if you ask the job.
Yeah, he said
Yes,
teacher.
yes, asked.
Yeah, and the examination also you started systematic. You start from the hand, the eyes, but you didn't mention what the hand rash, which is Janway, I think.
Yeah,
Uh,
I follow.
yeah, you have to
Yes,
mention it.
Oxford January missed, and also need to check that fundus because the rot spot is another
The
finding.
Ross spot, yes, Ross spot could be
Mm.
retinopathy. Yes,
Mm.
the also important thing you stressed on the pulse. You ask for the pulse regularity and synchronous in both sides. This is also important in such case. You can ask also about the nature of the pulse the volume. Is it collapsed pulse or no? Because most of these patients with regurg, they might have collapsed pulse, right?
Mm.
Apart from this, you cover the heart examination well, the chest examination, the murmur, the radiation, and heart failure signs. You missed the raised GVP. I think you didn't
Yeah,
ask.
I asked. I
You
asked. He
asked?
said no.
Okay. Remember always to do it while the patient in semi-sitting position. Don't do it while flat or sitting, okay?
Mm.
The edema also you examine. You did, I think you did great in all skills. Apart from exceeding the timer, you did great. and it's difficult
which
case.
is very bad.
No, no,
Which
no.
is
By the way, the case is very difficult, because you have a lot of finding. You have a lot of positive complaint, like chest short of breath. You analyze it. Then he told you about chest pain. You analyze it. He told you about abdominal pain. Then he told you about something else. So, yes, racing of the heart. So you have a lot of findings. You have to analyze all of them. But my always advice, try to analyze as short as you can to get more finding from others. You start to analyze the short of breath for, I think, 3 minutes, analyzing how the short of breath, what's the relation. So try to make every complaint at least 1 minute, or maximum 2 minutes. So as the main complaint, start with short of breath. So the onset course duration and the position and timing. It will give you a lot of hints. Okay.
okay.
Then past medical history, as you did exactly. You jump to the past medical history when you finish the complaint and the related complaint, like short of breath and chest pain. After that, you went to the past medical, which is very positive point for you. You found the hypertension, you found fracture of the knee, or fracture in the leg. If you don't ask these things, the past medical history, you will be in trouble. You will not suspect if he has a trigger for his infective endocarditis, right? That's why my always advice, please go to the past medical history once you finish the analysis of the complaint. I think all the skills you did great. But physical examination, identify the finding. Of course, it was by taking long time. But again, with the training, you will be much better, and also the online will be more longer than the face-to-face examination. I mean the exam. But the most important thing, to calm down and to stress on the finding, and try to link every finding to each other to reach the diagnosis at the end.
Mm.
Okay.
Okay, thank you.
Yes, she did well. I agree, Dr. Danvir. Any question or comment before moving to the next scenario? Can you post your scenario, Dr. Ryan, please?
Yeah, just give me a while.
No problem. Take your time.
Dr. Basil,
Yes.
in infective endocarditis symptoms in the hand, normally in the exam we will find this genuine lesion and also notes and all these things.
You have to search for them.
I will search for them, but I am
Yeah.
talking about the experience. Anybody in
By
the
the way,
exam found these
you will
things?
not find infective endocarditis in your exam. Why they will bring patient with infective endocarditis? But in the cardiac
Mhm,
station, the most
mhm,
important comment after you finish the positive finding, you have to say, I couldn't appreciate signs of infective endocarditis. He will ask you
mhm,
immediately, what are they, doctor? You will say, in the hands, genuine lesion, oscillatory reduce, splinter hemorrhage, in the
mhm,
eyes, rosy spots, in the urine, hematuria, and the murmur finding. He will tell you immediately. Once you mention this question, believe me, this is important question for every cardiac station. Always, every examiner ask them. Once you mention infective endocarditis in the cardiac station, he will tell you, please, doctor, let me know what are they, either positive or negative. So
okay.
also, one more point, I prefer to mention it, dental caries, or the teeth hygiene. You have to mention, I said before, try to make it a habit. Open your mouth, show me your teeth. Sometimes it might be the trigger for infective occurrence. He has surgery, dental caries, and he had a surgery, and it was the root of organism to go inside the body. So try to mention, or try to look inside his mouth for any dental caries. Okay. This is another, and I prefer Dr. Ryan and everyone, when you present the investigation, I prefer to say general, specific, and bedside. He will be impressed, the examiner, I mean, he will be impressed by this way. He will ask you, what you mean by specific? So you will get some time to explain some bedside, like what? In this patient, you will say, I will do ECG, echo, I will do urine dipstick. Why? It will give us a hint about the infective endocarditis. So I prefer everyone to start with this way through the investigation. Yeah, the general investigation, it doesn't add a lot of finding, but you will mention it. He will tell you what other general investigation you want to do. One of them, coagulation profile, once he's having any heart or valve replacement. One of this general investigation. As you said, for the specific blood culture, 12 hours apart, 2 sets, to look for the organism. This is the way how to present the investigation for any patient or for any diagnosis, okay? Any question else? Before moving to Mr. Adam William, 35 years, with abnormal movements.
السلام عليكم
عليكم السلام ورحمة الله وبركاته.
السلام
دكتور باسم
أهلين
دكتور
دكتور بدر.
ريان ودكتور تنوير يعني well prepared case وما شاء الله على دكتور ريان. أنا بس عندي
Thank you.
just tips just to gain your time in your exam
Mhm.
and just from the start, and this is very this is very common, is to after you just ask, would you mind to tell me more about the symptoms you've asked, as you said, and just ask before I go further, would you mind to let me know if you have any past medical. Yeah, so before you analyze the complaint, because exam cases, they have any past medical, they most probably they have past medical history. Most probably, because they want to see how do you link symptom to something. Okay, it could be most probably 65% of the cases you will have past medical history, you will have medication or something. If they gave you that, because shortness of breath could be many things, and if palpitation, many things. So if you ask from the start, you will gain your time. Okay, so you'll know that he has a past medical history of surgery, you past medical history of heart disease, have past medical history of hypertension. So it will give you time for that. And and the second things, you give him 2 questions for 3 times. This will affect the communication skills. Okay, be careful not to give 2 questions at the same time.
Like what, Dr. Adaya? I don't remember. Can you please?
You said, I don't know. It was.
I forgot.
Yeah, you said, for example, I can't remember actually.
Okay, no
Because
problem.
but this is because there is many complaints, so it's unfair for you
Yeah,
to do
yeah.
analysis for all the complaint. Okay, and please don't and don't give guided question. You said, is this chest pain like it's the same time with the shortness of breath? Just give him time to answer. Okay,
Mhm.
this when did it started? Okay, that's it. And go just link the symptoms. Okay, say I'm not sure, give him a hint. If he said I'm not sure, give him a hint. It's before or with the same, at the same time with a shortness of breath and so on. And otherwise it's fine. And before you just start this kind of presentation, you put your did you put your differential on the paper?
Yes, I put.
Okay, and you put that past medical history, medical, and all of this, because whenever you are in the exam, the 2 examiner, they have a checklist beside him. Okay, so when you said what the family, do you have any family history, they will do marks. The past medical history, family history, drug history, this has marks, but the more details of the one complaint, there is no too much marks. So if you just and try to, because try to do your case in just 8 minutes. If you didn't finish your full history, please go for examination and do the social and rest of thing after that. If you just said what do you do for living while he's, because now you are here in the in the platform, this platform, and there the patient will be sitting or sometimes sitting on the couch, sitting on the chair. You will ask him to go to the couch, and this will take time. Could I ask you, do you have any, what do you do for work? And while he unbutton his shirt, you know, you could have sometimes to ask the social history. Why is he's, you know, taking his top off, unbutton the shirt, you know? And yes, you could gain your time there. So because from the skills after the communication skills, it's the history. Okay, so that's good. You didn't mention any jargon, but you give him 2 questions at the time, because this is the communication, you know. So how do you just you good are you listening well to him, not giving jargon, and so on, so on, so. And after that, from the examination, the rest of the skill. So station 5 or the long station, if you pass the long station, the 2 long station, whatever you do in the other communication, you will pass, because here the 7 skill, you will mark the 7 skills. So be careful not to give a lot of time for history. After 6-7 minutes, just jump to the, and if you ask for the past medical history from the start before the complaint, analysis of the complaint, you will give, this will help you a lot. So you will be target, because the mark sheet is focused, target, history, and examination, not like the Irish exam. I didn't see the mark sheet of Irish exam, but here is, because if you ask just question from here, from there, after you finish, and if for the skin rash, is any skin changes, because sometimes it's not a skin rash, sometimes it's a skin color is changed. So, for example, if the patient has hyperpigmentation, vitiligo, or something, and so if you just make a habit, so, do you have any skin changes? He will tell you, yes, I have a skin rash here, or a change in the color of a texture, or tough, stiff, or anything. Okay, joint problem, any change in your bowel habits, any change in your urine. If you don't have time for the color amount, from the start of preparation, many tutor told me I have to say color, frequency, and so on, so in details. It's not accepted to say any change in your urine. So if it's not the main symptoms here, it's not the main symptom, you could say any change in your urine. That's it, because you don't have time. But they will mark you, ask about the urine. They will tick that for you, the 2 examiner. By the way, it's stressful if you, because the 2 examiner during the exam, both of them, they will tick, you know, you will see them hold the paper and writing something. Okay, so whenever you do something that you are do something, they will write it for, the candidate do this. They have to past medical history, social history, and so on, so on. So very important. If you miss one of the analysis, no problem, but the past medical history, all of them has marks. Okay. That's it. Thank you.
Thank you, Dr. Dalia, for the valid
welcome.
comments.
Thanks.
I just
Thank
want
you,
to say
Dr.
that some
Yeah, go
examiners,
ahead.
they say that they don't prefer, or sometimes they might not like that to ask about past medical history before analyzing the chief complaint. That's why I don't know, and I am in between.
Yeah, I
No,
know. But
No,
Yeah.
it's a depends. It's a depends. It's not like that, I think.
Then what
It
should I
depends
do?
upon
How
the
will I?
I guess the complaint first before this is my also opinion if you can follow or no, but I think it's important to finish the complaint.
Yeah, I think at least I can, maybe Dr. Dalia,
Yeah.
maybe I can do one complaint and then ask past medical history and then continue the rest of the complaints, maybe.
I think also from the complaint you can know or you have some idea about the condition. Like for example, chest pain with sitting forward. It subsides when the patient sit forward. So you catch a most important differential, which is pericarditis. This is one of the complaint analysis.
Dr. Rayan,
Yes.
I
Yes.
have a suggestion which is will solve this dilemma. Like, do you have since when this shortness of breath started? It started 2 days ago. Is this the first time, or you have it before? No, this is the first time. So you are saying that before 2 days you didn't have any shortness of breath. Yes, I don't have. So before these 2 days, do you have any other past history that I should be aware of? Do you have any heart problem, any like this? So you enter the past medicine through the analysis of the complaint.
I
Uh,
think that is a good idea.
Yeah,
Thank you,
and then
okay.
Dr.
go back to
Yeah,
complete the analysis. Yeah.
But
it's
again,
good. It's good idea,
yes,
Dr. Selma. But it's the habit for every candidate, especially if his exam is near. So you know,
yeah, don't disturb your yes,
yeah.
your skin.
But put in your mind that in the exam, the earlier the past medical history, the greater chance to pass the long station.
Okay.
So you will remember me one day, all of
Yes,
you.
Thank you.
Okay,
yeah,
so
we will do it, Dr. Dalia. Definitely, we have to do the past
okay,
medical history. But
okay.
in order, which order? This according to everyone, what he prefer.
I-
I
I've
think
came
yes,
across many cases. If we didn't ask about the past medical history,
yes,
this
exactly,
is
yes.
a little okay. So,
Yes.
by the way, during even the consultant here, and even they always ask about past medical history before everything. Okay, so this is the habit of most doctor in the casualty in anywhere. So they want to know with whom we are talking, with what background, So I'm talking with a patient with a background of cancer. Okay, I will listen very carefully to his symptoms. I'm talking with a patient with HIV. I'm talking with a patient with, so you know with whom you are talking. So I don't know. Try to do that and see, when you are practicing next time, try both methods and see, whatever you feel comfortable and you can manage your time, do it. Okay.
Yes,
Inshallah.
thank you,
Thank you
Dr.
so
Dalia.
much.
Again,
Thanks.
related to the analysis complaint, like myasthenia gravis, if you analyze it with the timing, you will know this is myasthenia gravis. For example, I get fatigued at the end of the day. This is one of the complaint analysis. I have short of breath, or I have fatigue, and this fatigue worsen at the evening. So from the analysis, you can catch the case. Okay,
Yeah.
again, everyone has his approach. Follow what you are comfortable, as Dr. Dalia said.
Yes,
Okay.
yes. Sometime, by the way, Dr. Basim, it's
Yes.
myasthenia gravis, but because it's associated with other autoimmune
Yes.
disease.
We,
So,
we we will never
and
deny.
sometimes it's a part of polygranular. Okay.
Of
So,
course,
or so it will give you, you will gain your time.
we agree, Dr. Dalia,
Okay.
but we will do it after analysis. This is my.
Okay.
But anyone, as you said, everyone has his approach. Please
Yes.
do whatever you are
Stick. Yeah.
comfortable.
Yeah.
Yes, exactly. So
As
if
long
your
as you
exam,
manage your time, that's,
yeah,
but please,
yes,
please, not more than 8 minutes. And you could
exactly,
do it
yes.
like a routine. Go
Mm.
to the after 8 minutes, even you don't finish, go to the and do the systemic review later on. After the patient, okay, the systemic review, just give put like emergency plan. If I don't have time, I'm wasting my time, I will ask a
Yes,
systemic review, the urinary. Do you have any change in your water work? One
exactly.
question. Do you
One
have
question
any change
only.
in
Yes,
bowel habits? If I didn't ask about the GIT, any change in your bowel habits? Any tummy pain? Okay.
exactly.
Okay. This is for any skin changes, any joint pain. Okay. And
Yes.
something like that, you two to one question. And for the any weakness or any change in sensation for the CNS, and do like then just the examiner will take that. Dr. Rayan did the systemic review quickly, because you are, mashallah, you are, yeah, fast. Okay, so
You
you
know,
could
Dr.
you could
Dalia,
do it. Yeah, you
yeah,
could
I
do it
made
30 seconds without stress of the case.
yes, I made as a
Thank
short
you.
video on the channel, including it's called the video how to perform systematic review, systemic review in a very quick manner. Why? Because you might have the diagnosis. I spend the video questioning. It takes only 1 minute 45 seconds. So it's almost 2 minutes. You can finish the system review or systemic review if you already know the diagnosis or about to know the diagnosis. Just to finish the system review, as Dr. Dalia said, you have to do it, but make it at the end and make it as fast as possible. I think all of us know that, but sometimes we have a beginner or still some doctors just finish the part two and they have to know how to do the systematic review. I made this video on the channel. He can or she can review it.
Just
Thank you, Dr.
question,
Daria,
Dr.
for advice.
Basim.
Yes,
Yeah, that's
yes.
great. Great. Thank you,
Mhm.
Dr. Basim. It's that the whole question of the systemic
Yes,
review
yes.
or
Whole question from
okay.
head to toe. I made it from head to toe. It
That's
takes,
yeah.
2 minutes
Okay,
or
that's
less than.
great, Dr. Basim. But on the other hand, sometimes if you just ask like that because it's focus history, not all the history. So
No,
sorry
this
for
is I wrote if you have a clue about the diagnosis, but you want to go through systemic review. If you have a clue about the diagnosis. But
you
if
have a
you don't
clue.
have, if you have a clue about the, like in this case, infective myocarditis, you might, I mean, you might get the diagnosis from the complaint and the relevant system. That's why you have to go through the other system. You might have tummy pain or tummy discomfort, which is splenomegaly. So it will be picked up through these questions. I made it like this, the common question that can guide you to have the positive finding in systemic review. Get
Yeah,
it?
I got you. I got you. But I want to just to highlight something.
Mhm.
In this exam, particularly I'm talking about PACES. It's need
Yes.
not to be like full, question of the systemic review. So it will give like you are in the the final year of examination of the college, graduation year. So it's will give this like impression that you are just but it's more impressive that you know what you are asking of about. So Dr. Rayan, she knows that will give any examiner that she knows that what she's thinking about. Okay, so that's what I mean, because if you read the mark sheet, okay, it's they ask if that how it's satisfied for the history taking, how it's satisfied that focus history and target examination. Okay, so just try to make it like analysis of the complaint, analysis of the system involved, and the general, which is most important system ever. The general fever, loss of weight, and all of that. And then after that, any association. And if you don't have any association, just put the endocrine and the what it's called rheumatological. Okay, so this is the most important, and it could be association with other thing. But here, cardiopulmonary, shortness of breath, cardiopulmonary, and anemia. This is the most important differential for the case, and they will need to ask about that. They have to ask about all three differential. Okay,
Yes.
thank you.
Thank you, Dr. Dalia. Thank you so much. I think we can start, Dr. Tanvir. You ready?
Yes, yes.
Dr. Ayan?
Mashallah.
Yeah.
Okay.
Let's start.
You start timer?
Yes, here you go.
Yes.
Start.
Okay. Hello, sir. I'm Dr. Ali, one of the doctor in this clinic today. Can I confirm you are Mr. Adam, 45 years old?
Yes, doctor.
Okay, Mr. Adam, today I came here to discuss regarding your health condition. Is it okay for you?
Yes, doctor.
Okay, can you tell me more actually what happened with you?
Actually, doctor, I'm having this abnormal movements in my body. I don't know. I'm just worried. What's the reason? I will share. Okay. Continue.
Okay.
I will share. Yeah.
Okay. So I'm really sorry to hear that. So I'll discuss regarding your health condition and do some examination, and later we will talk about its solution. Is it okay for you?
Yes, doctor.
Okay. So can you tell me actually what do you mean by this abnormal movement?
I don't know, doctor. You can see. I sent in the group. Uh,
In the group?
I don't know. Yeah, my hands are moving. My legs are moving. My head is moving.
Okay. Your hand is moving. Yes. Okay. Okay. Just a minute. I'll see that. Okay. 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 So exactly from how many days it started?
About 1 week, doctor.
1 week. It started yesterday or by gradually?
I believe gradually worsening over the past 1 week.
Gradually. And I saw in the video that it's for your like both hand and both leg are moving. Is it?
Yes, yes, doctor.
Okay. So can you control it? Like you can control it out. It's without control it's happen.
No, I cannot control it.
Okay. Can you tell me that any factor making this movement more? I mean, any medication or if you are not sleeping properly or any tension, is there
No,
anything related?
no,
Okay.
doctor. No medications I'm taking.
Okay. So is there any factor to relieve this? I mean, if you take rest or sleep or any medication, you feel better. Is it like that?
I didn't notice. No,
Okay. And this is happened for the first time, like last 1 week, or previously also you happened this problem
no, first time.
first time. Okay. Is there any other associated condition? I mean, do you feel that your body parts become weak? I mean, hand or leg become weak?
Weak? No, no,
No, weakness. Any problem with any sensation?
no.
Okay. So I just want to know some other history, some general question like, do you feel that you are feeling weak than before?
Sorry. I feel weak
You
or
are
what?
feeling weak, yes, weak or
Weak.
tired than
No,
before.
no, no, no,
Any anybody said you look pallor or something changes in your color in your body?
no. I didn't notice.
Okay. Any lump or bumpy changes in your body?
No,
Any weight gaining or weight losing?
no.
Any headache with that jerking movement?
Yes, doctor. You are right. Actually, I'm having headache.
Which part of your head?
My whole head, doctor.
Okay, how much it's grade? If it's 0 is the low and 10 is high.
No, it's my mild headache. Maybe around 4.
Okay. So is there any problem with your vision?
No,
Okay. And what type of the headache is like burning pain or something compressing down?
no. I think dull pain.
Okay. So do you have any problem with your breathing?
Breathing? No,
Any chest pain?
no,
Any coughing?
no,
Any tenderness in your, I mean, any pain in your tummy?
no,
Tummy distension or swelling?
no,
What about your water walk? Is there any changes? I mean, frothiness or color changes, anything?
no.
What about your bowel walk? I mean, back passage, it's okay. Or hard or loose,
Yes,
something
yes. No, normal.
normal. Okay, I just want to know that recently did you get any head injury?
Head injury? No,
Okay, any type of that recently you got? Anybody said that you got bug infection? I mean, high
no,
rest temperature recently. Okay,
no.
so I just want to know some other things. Do you have any pain in your hand or leg?
Pain? No,
Any swelling in your any parts of hand or leg?
no swelling.
Any skin rash or any skin changes in your face or in your hand, leg, anywhere?
No,
Okay, so I just want to know some other things. Do you have any temperature preference, hot or cold temperature preference?
no,
Okay, any swelling in your neck?
no,
Do you feel that your frequency of the urine, I mean, water work increase?
no,
Okay, I just want some other information. Do you have any long-standing disease previously?
no. I am totally normal before.
Okay, is there any medication you are taking for any condition?
No,
Okay, is there a similar condition running in your family?
no,
Okay. So what you're doing for living,
I am a teacher.
how much it's affecting your daily life?
Yeah, it's affecting me a lot, doctor. I cannot do my daily activities. I cannot do my work. I am
I'm
embarrassed,
really
doctor.
sorry. Yes, I'm really sorry. I understand your situation. We can involve that occupational health service person, and also I will give you some sick leave, so it will be helpful, I think, for you.
Mhm.
Is it okay for you?
Yes, doctor.
Okay, but if you don't mind, I ask some personal question. With whom you are living?
With my wife?
Okay. Do you have any other casual relationship except
No,
with your wife? Okay.
no.
Do you smoke?
I do smoke, yes.
How much and what duration, please?
I smoke a lot, honestly, doctor.
Okay. So, how many cigarette or duration can you tell me?
Yeah, maybe 1 pack per day for the last 5 years.
Mhm.
And yeah,
So I just want to advise you better to stop the smoking, or even if you want, I can refer to smoking cessation clinic because it can affect your present health condition. Is it okay for
okay.
you?
Okay, doctor, yes.
Do you take alcohol?
No,
Okay. And if you don't mind, are you take any recreational type of medication?
never.
Okay. Thank you, Mr. Adam. So what I feel that you have abnormal body movements on the last 1 week, your hand and leg, and it's not by your intention, and that is not relevant with your any past medical history or any medication, and you are not taking any recreational medication. You are a smoker, and I am already advised to go to physician clinic, and you don't have any family history like that.
Mm.
Is there anything I missed?
Yes, doctor. I am having dizziness. I feel nauseated. I vomited 1 time.
Okay, since
And I am
when?
also having some confusion, like I am not my normal.
Mhm. Okay. Confusion means what, like since when you feel confusion?
Same, all this happened this week only, doctor. I was totally normal before, and I cannot
Okay.
concentrate in my work these days.
Mhm. So do you feel that, did you check any medical attention? I mean, seen by any doctor, your blood pressure, blood
No,
sugar level checked that time?
no, doctor, you are the first one. I found this all like worsening, so I came today.
Mhm. And due to that vomiting and nausea, did you take any medication? I mean, from the uh,
No,
by by yourself?
no, never. I vomited once only, but I
Okay.
feel nauseated most of the time.
Okay. So, Mr. Adam, I want to do examination. Is it okay for you?
Yes, doctor, please.
Okay. So first of all, as I saw that patient is a jerking movement, it looks like Korea type movement and the visual movement involuntary in the both limbs. And so I need to go for check for vital signs, blood pressure, temperature, respiration,
Mm,
blood sugar. What about reading? Everything okay?
normal, yes.
Everything normal. Okay.
Yes,
Then I need to go gently by washing my hand. I need to and warming my hand. I need to go for my power. So far, I will try because he's jerking. I'll try my best to check the power. Is it okay? Power normal?
normal.
Okay. What about that tone, hypertonia or hypotonia something?
Nothing. Normal.
Okay. I just instruct him to maintain the coordination like finger nose test. Can he do this?
It's difficult because of this abnormal movement, but it's normal.
This is yes. Okay. Then I need to just check touch sensation by cotton. Is it okay for him?
Normal, yes.
And also in the inspection, I just check general looking if there is any facial rash, any backed nose, any skin tightening, shining, any nail changes, any muscle wasting in the hand or leg, anything changes there.
Nothing.
Okay. Now I need to do that the milkman sign. Like I just tell to hold my finger. I just and I'm trying to remove it. Milkman sign. Is it positive?
Milkmaid sign?
Yes.
No, negative.
Negative. Okay, and after that, I need to check anemia, jaundice. Is there anemia or jaundice, anything?
No,
Any thyroid swelling?
no,
I need to check that Harlequin tongue. Can you show me your tongue? Like he's rapidly protruding out and taking inside like that.
yes,
Okay. Then I need to go for chest examination. Any abnormal heart sound, murmur, or any
no,
chest palpitation, anything? Okay. Then I need to. I already checked the pulse. So is there any tachycardia or something?
no tachycardia. No.
Okay. Now I need to go for abdomen. Is there any abdomen tenderness?
No,
Okay. Any organomegaly?
no.
Can you extend me for please just to check the proximal matrix? I'm sitting to
Sorry,
standing.
sorry.
Sitting to standing. You can sit to stand.
Sit stand normal, yeah.
Okay. I just need to check that any tone power, any abnormality in the leg.
Normal.
Normal. He can maintain heel shin difficult.
What is it? Sorry.
Heel shin test
Heel shin
coordination.
test. Its coordination is normal, totally normal. But because of the abnormal
Normal.
movement, difficult to do. Yeah.
Abnormal movement. Okay. Then I need to check touch sensation by cotton. You can.
Normal. Normal.
Okay. Okay. And I just asked some question regarding his vision. I need to check his vision, like visual acuity and the field of vision, any diplopia, anything there positive.
No, normal.
Okay. And I just need to check his speech. Can you tell whether hippopotamus? You can tell it.
Speech normal, yeah.
Speech normal. Okay. There is a no nystagmus, is it?
No nystagmus, no.
Okay. Then I need to go again for the legs or remaining. Is there any leg edema or back
No,
edema?
no,
Any back tenderness?
no.
Okay, Mr. Adam, can you please walk for me? Is it possible
Sorry?
for you? Can you walk for me? Is it possible for you?
Walk.
Yes.
Skip,
2 minutes
skip,
left. 2
skip.
minutes left.
Sorry. Sorry.
Skip
What type of
walking. No
walk?
need. No need to walk.
It's
Skip.
okay, keep walking. Okay. Any bedside, anything there? Beside the bed, any wheelchair, any
No,
walking stick, anything there?
no. He
Okay.
came with his
Okay.
brother. Yeah.
Okay. I just need to ask some common question regarding that memory. Can you tell me that who is the president of the US?
Yeah. What is it? Sorry?
President of the US, United States.
Yeah, he can tell.
Okay. So that means there is a no dementia. Okay. So what's your concern, Mr. Adam?
Doctor, what's the reason for this abnormal movement? And can you treat me, please?
Yes, I highly appreciate your concern, Mr. Adam. Actually, from your history and from your examination, what I found is abnormal movement is one of the type of the brain condition. We are calling it dyspnea. Don't know about the term. So it can happen actually for the different reason. Even sometimes it's from the family reason. Sometimes it's due to the hormone, or sometimes it's related with the joint, or sometimes it's related with some medicine. So I need to do your some blood test and I need to do a brain scan to rule out actually what is the cause. And also I will involve our occupational social worker, our brain doctor for the proper management of this. Is it okay for you?
Okay, doctor. Thank you, doctor. Doctor,
Great.
can I drive?
Yes, thank you for asking this question. Actually, you cannot drive in this condition because as you have jerking movements, so maybe it will be dangerous for you and for other persons. So I want to advise that to stop the driving.
Okay, doctor.
Is there any other concern?
No, thank you.
Okay.
Okay, time is up. Is there any other question?
Yes, can you present your case?
Yes, this young man, 45 years old, Mr. Adam William, he came here with the abnormal jerky behavior movement of both upper and lower limb, which is actually involuntary. And there is no history of the brain injury, I mean head injury, and no history, past medical history of that very long-standing disease, and no medication history which can cause this abnormal movement And I don't find any the family history of, especially I'm searching for Huntington disease, I don't found. And I also searched for that hyperthyroidism and SLE issue, but I don't find also there. And we don't have any heart disease previously. And this is not related with movement or rest. It's continuously jerking. And I don't found that any other sensory motor deficit of this patient. Both power and sensation is okay. Coordination is difficult due to the jerking movement. And I found I don't found that milkmaid sign is negative, but I found there is a harlequin tongue, and his chest is clear, no murmur, and no abdominal tenderness, no leg edema. So above all of this finding, my main diagnosis is chorea. I need to rule out by doing CT scan and MRI of the brain, and also I need to do some basic blood tests to rule out.
Okay. What causes of chorea do you know?
Actually, there is a multiple cause, like from the family, it's a Huntington chorea, but I don't find this patient family history. And there is a chorea gravidarum, which is related, mainly it's happening in the female. And there is a Sydenham chorea, which is related with the rheumatoid heart disease. I don't find here. And also SLE and thyrotoxidosis disease, it can cause this also. I don't find here feature like that. And some other medication actually not causes chorea, but can causes dystonia, especially anti-dopamine medication, antipsychotic medication. But he don't have history like that. And some other condition can causes abnormal movement, I mean cannibalism, but it causes unilateral problem. And some other condition like atherosis, pseudoatherosis, that is the another, not giving this type of the feature.
Okay. What are your investigations?
So first of all, I need to do some basic blood tests like CBC, SFC, BTC, and lymphocyte and anemia. I need to check liver and renal function tests and electrolyte check for any electrolyte imbalance. I need to do urine to check any protein or blood. I need to do thyroid function test. And also I need to do that autoimmune profile and connective tissue disorder ruled out, especially that ARA, anti-DSD, and it ruled out SLE. And I don't find actually here patient the familial association, but if there is a familial association, I need to do genetic test to rule out any like Huntington disease. And also I need to do the main specific thing is CT scan and brain MRI to rule out any structural abnormality. And also I need to do some blood sugar level to rule out any hyperglycemia related or any glucose abnormality related or not.
How are you going to treat this patient?
So first of all, it's mainly the supportive treatment. We need to educate and counseling the patient. We need to involve the neurologist and specialist, nurse, and also social and occupational support as a non-pharmacological approach. And from the pharmacological approach, we need to actually rule out the cause, and according to the cause, we need to treatment of the cause. And also this abnormal movement, we can give tetrabenazine, which can be helpful to reduce this type of the jerking. And we need to rule out any other complication or any other cause, any cardiac issues, we need to also rule out.
Okay. I want to ask you some few questions, if you don't mind. So
Okay, sure.
this presentation within 1 week, is it considered acute or chronic?
Is it actually within 1 week supposed to be acute?
Okay. So can you think of anything that can cause acute chorea? Like most of the
Acute
things
chorea.
that you mentioned are mostly chronic, except if the patient took a medication. But he told you that he did not take any medication. The others, the endocrine,
Yes.
the family history, all of these chronic. So
Mhm.
can you think of
Like
anything that
brain
can
injury, head injury
you
is the one
you
acute cause
you
I asked already.
you asked, yes,
And
and it's
medication,
negative.
yes.
Negative.
Yes,
Anything
medication
else?
is the another.
Negative. Anything else?
And acute
Okay, let me help you.
medication, yes.
If you did for this patient bedside pulse oximetry and you did bedside ABG, the pulse oximetry was normal, the ABG was low, hypoxemia.
So there is a one history like methanodobinemia.
Huh?
B.
Sorry?
Methemoglobinemia.
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 Okay. Forget about this. Anything else?
In the ABG, it's the oxygen is low or carbon dioxide. I mean carbon dioxide poisoning.
CO poisoning, yes. So I think you can add one question. Ask the patient since it's acute.
Hello.
Hello, Dr. Ryan.
Hello.
Yeah, your sound interrupts, Dr. Ryan. Check your internet, please.
No sound.
Yeah. Dr. Ryan, if you are talking, no sound. Yeah, Dr. Salma comment, a lot of F, difficult. Yeah, it's difficult, but we are learning.
Carbon monoxide poisoning. I heard first actually because I ruled out all the cause, but really I don't know that carbon monoxide poisoning can
Yeah.
cause this.
I always say, Dr. Tanvir, I always say, whenever you catch the diagnosis by comment, better than catching the diagnosis from the case scenario. Why? Because now you will learn this topic and you will never forget it. So it's okay to miss the diagnosis in the session, but in exam we have to know the diagnosis.
Yes. But carbon monoxide poisoning, I think it's not typical because I heard first time.
Yeah,
I
difficult.
don't know that.
It's sometimes presenting with headache, sometimes with the headache. I think most
Yes. Headache here
most common
one
presentation is
issue,
headache.
but supposed to be pulse will be like bounding pulse, pulmonary edema, respiratory distress, headache, confusion. Yes, headache, confusion here.
Yeah. But with the Korea, never I heard about it with Korea.
Yes,
Anyway,
actually, first time I heard the Korea.
Yeah, but the most important also, you ruled out all causes, trauma and family here, Huntington, Korea.
All of the cause, what I know, I ruled out.
SLE, you rule out all the rheumatic pregnancy, and which is not the case here. But now we know the new potential. No need to know the diagnosis. They only need to know, yes, I agree, Dr. Daria. So they will know from your approach, you are expert, you are professional. And from the approach, I think you can catch the mark. They will give you good mark. I agree with Dr. Daria. Thank you, Dr. Daria. So your approach was okay, and also the examination, although we didn't link with CO poisoning, which is very difficult. I don't know. I think the valuable question in this scenario to ask about.
I just tell you, like if CO poisoning supposed to be give slapping tremor, bounding pulse, pulmonary edema, headache. Here actually headache is going headache cause confusion going for CO poisoning, but no pulmonary edema, no bounding pulse, no slapping tremor. So
and sometimes they are linking the partner. If the partner has the same symptoms, so it can give you a clue. I don't know if you ask about any partner or any history of family, the same condition. I don't know. Did you ask this type of question?
I asked in the similar condition running in your family, like any Korea, supposed to be if carbon monoxide poisoning, supposed to be it will be most of the family member affected. You know that one cause is like headache. So then one examiner gave me headache. He said that headache it's happened most of the family member. This is a clue for carbon monoxide poisoning.
Yes. I believe it's very difficult, but again, the approach was perfect. But don't forget the driving. Always with CNS complaint, you have to ask about driving. Okay. Also, the analysis of CNS, I think you miss the memory, and I always recommend to ask about.
I asked about the memory. I asked about who is the president of US to check the memory.
Yes. So SMS, memory, and sleep and stress. SMS, memory, sleep, and stress. I guess you covered most of the points, but we are waiting for Dr. Ryan to comment, please. If you are back, Dr. Ryan. No, she's not. Okay, we can hear.
Dr. Basim.
Yeah, Dr. Azhar,
I
go
got
ahead.
one or two comments for Dr. Tamil. Mashallah, he is doing very good. But it is my advice that sometimes he is talking very fast. So the examiner maybe cannot understand. That's why Dr. Rayan, she interrupted many times. Sorry, I could not understand. So please, a little bit slow and try to pronunciate clearly. Maybe the examiner, if he will not listen, he will not say, please repeat
I
it.
I guess this is due to the online session, Dr. Azhar. I don't know. I think maybe due to the online. Is it,
Yes,
Dr.
exactly. It's due to the online because we are all like familiar environment. I will not talk like this
So
way
anyway,
in front of the examiner.
let's take the good point from this advice. Be clear while talking anywhere, either online or face to face or in the exam. Just be clear, and the examiner can understand what you are, because you might be in hurry and you history maybe some question will be not understandable by the surrogate, and he will ask you to repeat, and it will take time, of course, from you.
Hello,
So
sorry,
yeah,
my connection
welcome
got
back.
lost. Thank
Yeah,
you.
your comment,
What?
Dr. Daya. We commented some about the performance, so you need your comment now about the case.
No, I think Dr. Tanvir did very well. Like it's in the end, it's an approach. I think,
Exactly.
yeah, you did very well actually. Only because of the acuteness of the illness, you can ask just anything that you were doing differently last week. Um, Otherwise, I think you did well. And even you did the examination of the chorea very well, the milkmaid's sign and the Jack in Box tongue.
Yes.
Yeah, for the differentials, I think you also mentioned the good differentials. You can also consider autoimmune disease, SLE, Sjogren.
SLE, yes.
Yes.
Yeah.
Endocrine, you are right, hyperthyroidism can cause infectious, like rheumatic fever, post-stroke, post-brain tumor. I think this case was raised before, I don't know, maybe in Sharjah Center. And I think they wanted the candidate to do fundoscopy. Maybe because of the brain tumor, I am not sure, honestly, why to do fundoscopy. But they wanted fundoscopy and they wanted driving. So these two, if you don't do, I think they failed the station. This is what I heard before.
Oh my
So,
God. Regardless to the approach, if he didn't offer the
this is what
driving,
I know. Wallahi, the candidate who discussed this case, I don't know. He was a very genuine candidate, really. And yani, mashallah, he did a great job. But he did not, I think he missed the driving and the fundoscopy. So they
he
failed in
failed
the
the
station.
station.
Yeah. Driving is important, honestly. Driving is important here. Maybe
Yeah,
fundoscopy for a brain tumor, maybe.
I agree. Yes, the driving was important than fundoscopy, but
Yes.
always we have to remember in any CNS complaint to offer it. They will not give it to you, and they will not have the fundoscopy. Most of the cases, by the way, I don't know if other centers they have the fundoscopy itself, but we have to be ready and we have to offer it. It's nothing, and it will not take time to say I would like to do fundoscopy, and you will get good mark by this question. Why? Because they will know that you are ready to do everything to finish your complete examination related to the complaint. So better to offer it in any CNS related complaint. This is my advice. If they have it, have a look. If they don't have, at least you offer it.
Yes.
Okay. Yeah. Any other comment, Dr. Ryan?
Of the toxins that can cause, carbon monoxide poisoning and mercury poisoning can also cause. I think that's it. It's important here also to assess the patient, like because with this chorea they cannot eat, maybe because of the movement. So you can ask if this is affecting your like you're eating in any way. They cannot hold, they will spoil the stuff. Although it's 1 week only, but this can lead to malnutrition on the long run. So, and also it can lead to physical injury from the involuntary movements and falls.
Yes.
So you can say risk, like fall risk assessment.
Yes, I believe also a question of how you cope with this in your daily activity.
Yes, you are right. important. I
Yes.
think that's mainly it.
Okay. And the examination, he cover all the signs and
And the
symptoms?
examination, he did perfect.
Mm.
Yeah, he did perfect.
That's
And
why
it's important to examine the heart as you did, or because it can also involve the heart.
rheumatic heart, yes.
Yes. And carbon monoxide poisoning itself can also lead to like problems. ECG is important, arrhythmias. So it's important to examine the heart.
Tachycardia, it's not significant arrhythmia. Might be tachycardia.
But I think they are at risk with severe cases. They are at
Yes,
risk of yes.
Yes. Okay.
Otherwise,
the
you did well.
previous history important here. I think any previous attack of the same condition, and
He
the acute
asked.
onset, yes, I believe
Yes.
about the condition itself, how to approach the acute onset, as you said, something is really acute within 1 week to have such movement, something weird. It's not Huntington, of course. Huntington, he will stay for a long time, and he will suffer from other symptoms like memory or cognitive dysfunction. Anyway, again, the approach was good, and I believe
Yes.
he can get a good mark.
Yes. Just don't forget the driving and the fundoscopy.
Yes, and you were also very kind surrogate when you asked him about driving. But not all situation you have kind surrogates. Maybe
Yes.
you will have this different surrogate, and he will not tell you. This is instructed by the examiner, by the way. It's not him. Okay, let's open the discussion. Anyone has comment? Well done, Dr. Tanvir. You have any question, Dr. Tanvir?
No. Thank you for giving all of your comments.
It's good to practice a lot of cases and to know from everyone and to practice with different participants. I prefer this school. Whenever you practice with different partner, you will learn a lot of things. Like Dr. Ryan today, she gave us a new topic, CO poisoning in the form of Korea. I believe you have, or we have, all of us to practice with different partners to catch a lot of findings and a lot of cases and topics. Thank you, Dr. Tanvir and Dr. Ryan. Now we can open the discussion. Anyone has comments?
Thank you all.
Any question? Sorry, Dr. Najla here. Sorry, we waited for you, Dr. Najla. She messaged me late. But wallahi, we wait for you maybe 12 minutes. Then Dr. Ryan was volunteer.
Yeah, hello. Yeah, sorry for the inconvenience. I thought it is an hour later, Ramadan timing. Sorry, I'm really sorry.
I said 11:30 p.m. KSA. We just postponed 30 minutes.
Okay. So I counted 9:30 UK. I didn't thought it is 8:30. Sorry for that.
No worries. Okay, we'll give you another day, inshallah, priority. Thank you, Dr. Najla, as well.
Thank you
Any
very
question
much.
or comment? Oh, thank you. Let's read the comment. Dr. Rabia, welcome back, Dr. Rabia, in the session. Involvement of CNS is emergency. So what do you mean, Dr. Rabia? We need to hear from you the neurological point of view, as you are a neurology consultant, if you are still here. I hope she didn't leave. No.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
الباس
Yes.
كيف حالك؟ هلا بالنسبة للكربون مونوكسيد it is a differential for this regular manner, this rhythmic chorea, or just a bizarre movement and rigidity like that?
It's one of the differential.
It is like this rhythmic, regular.
The same, yes, Korea.
Yes, it is differential. I posted the differential of toxins in the group. You can see it.
Yeah, so
Carbon
it's as a
monoxide, the
toxin.
first one, and the first one, yeah.
Along with mercury, Dr. Ryan, mercury and
along with
CO?
a lot of things, along with a lot of things, exposure
Yes.
to carbon monoxide, manganese, thallium, toluene, methanol, cyanide, even glow sniffing.
Oh,
This all can use abnormal neurological movement. I mean,
Korea, exactly.
This regular
Korea.
manner,
particularly, yes.
rhythmic manner.
Yeah, they are saying as Korea. It's as a Korea.
Yeah, it can cause chorea. I am not sure about the rhythmic manner, honestly. I just took a video from YouTube, and this, by the way, this video is for a Huntington disease patient.
Yeah, is this Huntington?
But yes, it's a Huntington disease patient. But I wanted just to bring the video of the chorea-like movement, and he got it that this is chorea. So here we're discussing about toxins causing chorea, just to to change the case, because we know Huntington is a case, and we know Wilson disease is a case.
Yeah.
So just to open the discussion for new causes of chorea, carbon monoxide
Perfect.
poisoning is one of
Yes,
the
perfect.
causes.
Anything was, I was not following from the start. For history, anything was related for this Korea? For carbon monoxide,
Headache,
carbon monoxide. No.
headache, nausea, vomiting, and confusion
Uncle and sister
for
had the
1 week.
same disease.
Yeah, go ahead. Sorry to interrupt you, Doctor. Go ahead,
For-
then I will present the video. Yes,
Yes.
go ahead.
for 1 week, and there is history of barbecue and heavy smoking in-house.
Barbecue and who's smoking.
But this barbecue you have to ask for. If you didn't ask, you will not get. So you have to ask about any specific.
Barbecue.
Yes. It should be like that. Yes. Thank you. Barakallah.
So, how to ask her? You have any occasion?
No, Dr. Basim. If you ask me any special thing that you have done last
Yeah.
week, I will
So
tell you.
say, yeah. I have a party with barbecue. Oh, nice, Doctor. Very funny.
Anyways, it's just for learning purposes. Yeah.
Yes, sure. And the other question also, any change of your ventilation system. This is very important. It might be the clue. Any change in your house or any ventilation system problem recently, it will be also as a clue.
Yes. I think if Dr. Tanvir did not put carbon monoxide poisoning as a cause of chorea, he will not think of it. Maybe he didn't know it.
Yes.
That's why he did not ask.
I
But
believe,
if he knew,
me really, I didn't remember about carbon monoxide as the cause of chorea. But thank you for question. It's nice to know it.
yeah, thank you.
Okay, let's see the video one more time. And again, it will be also the same
Maternal
definition of
uncle and
Huntington
sister
chorea.
had the same disease.
Him and the sister.
Maternal uncle and sister had the same disease.
One more, last time.
Maternal uncle and sister had the same disease.
Yeah, also the comments is very valuable here. She said the partner and the sister had the same complication or same presentation, right? Isn't Dr. Ryan? This is what I hear also.
Yeah. She said, I think one of the family members, uncle or something.
Yeah. I think they attend the same barbecue part.
No, this video is for Huntington disease Chorea patient. This
okay.
video. Yeah, I just took it to see the movement.
Yeah, you cook it. Yeah, you cook it.
I cooked it. Yes, I cooked the case. Exactly.
Okay. Yeah. Okay, so it's Huntington in the video, clear.
In the video, and this is Huntington patient.
But again, here also there is family history or
family
at least
history.
partner with him or the one attended the party.
If he asked, I will tell, but he did not ask.
Yes. This is related to the onset, so we have to think about why acute onset. Okay, Dr. Tanvir, any question or comment from others? Kindly, can you post the rest of the differential of chorea in the group? Yes, we will. It's a list. You have to fill the questions related to each one. So Sydenham chorea, which is related to the SLE and the rheumatic heart disease, or the opposite, Sydenham for rheumatic heart. I mix, Ryan, you can remind. Sydenham for the
Sydenham for rheumatic heart disease. Yes.
For rheumatic. And SLE also one of the causes.
SLE, one of the causes. SLE antiphospholipid.
Pregnancy.
Pregnancy is called chorea gravidarum.
Yes.
Endocrine thyrotoxicosis
And
cases.
and Huntington itself.
Huntington, yes. And toxins,
The most
carbon
common.
monoxide and mercury poisoning. And
Yes, rheumatic heart, yes.
Some drugs.
Dr. Basim, I think it will be more organized if you put it as categories, as up to date is putting. Yani autoimmune and inflammatory, endocrine, like this. You will not forget. They started with vascular first, and then they put autoimmune related SLE and SLE mainly, and Sydenham Korea number 3, and number 4 paraneoplastic Korea. Paraneoplastic. They put breast cancer, thymoma, lymphoma, renal cell carcinoma, paraneoplastic. Number 5, they put other immune mediated choreas, and then they put metabolic or endocrine. In metabolic and endocrine, they put chorea gravidarum, hyperglycemia, thyrotoxicosis, and last they put infectious disease, yes, and last toxin, which is toxin, as I post in the group. There is also drug induced. In drug induced, they put oral contraceptives and levodopa.
Okay.
Antipsychotic also, like metoclopramide, prochlorobrazine, domperidone, rarely. What else?
Yeah, I will
Senile
just add.
senile chorea.
Yeah, in the old age. Okay. So,
Mm.
in exam purpose, it's difficult to remember all these causes. So, what I prefer, this is also my opinion, and as you want to follow or not, take the common by common. So, the commonest is Huntington. You have to ask about family history. Then about
Hereditary Huntington and Wilson.
yes, this I mean take the common by common, not as a screen for the all categories. You might miss the common. Start by the common,
Yes.
then the least common. This is my what I prefer. Yani. Okay,
Yeah.
but you're right. You have to know all these cases, all these causes, and to roll out one by one. But if you take all the time to roll out one by one, you might waste a lot of time. But if you ask about the common, you might catch the case. Okay, so if you said I will ask about the common is Huntington, of course this is the commonest in the exam ever. You will know it from family history. So at least you know the case, then you can roll the least common after that, the SLE, the rheumatic heart disease, and the toxin or drugs. I guess this is fair enough for the exam purpose. Pregnancy, of course, if you have female, sorry. If you have female, either pregnancy or OCP, as you said. Clear now? Thank you, Dr. Salma, anyway, for your comments. Yeah, thank you.
Yes.
Let's read the comment quickly. If someone has comment, he can comment. I'm reading the comment. Kindly, can you post the yes, the rest we will post it. Central lateral vein occlusion induced chorea. Dr. Muhammad Sardar. Oh my God. From where this case? It was an exam or case report or what? Dr. Muhammad, if you are here. Central lateral vein occlusion in polycythemia rubra vera. Induced chorea? It's first time to hear about. I think he left also. Involvement of
I
CNS
think
is
Dr. Basim, he's justifying the fundoscopy. Why to do fundoscopy? I think this is what I got from Dr. Muhammad. So we do fundoscopy. Maybe that's why they wanted the fundoscopy. Because they wanted fundoscopy. They in the comments, in the feedback.
Okay. Involvement of CNS, Dr. Rabia, Dr. Tanvir, Master of Differential, I believe. Yeah, Dr. Tanvir, mashallah, is expert and professional. Thank you, Dr. Mona. I think no more comments. Anyone has questions?
So polycythemia vera is also one of the causes of chorea. So I think Dr. Muhammad meant that polycythemia vera can cause central retinal vein occlusion leading to chorea. So we have to do fundoscopy to rule that. Yeah.
Okay, but Dr. Selma didn't mention it in the causes. I'm not
It's
sure
one
also
of the
about it.
causes. It's one of the
Really?
causes. Yeah, I sent
Okay.
it in the group. Yeah.
Vascular. When I said
As a vascular.
vascular,
Okay.
yeah, vascular, that means if you want me to read it for you, it's okay, but
Yes, yeah, go ahead. I thought vascular means stroke, but if you have something else, yes, please mention it.
Yeah, that just I jump quickly for it because I
problem,
want
read
to
it.
go and read about Korea more. But
Okay.
just I give you the titles only.
Okay.
I only read the titles.
So the vascular
But
include a stroke and
let me just find it.
yeah, if you can.
Polycythemia vera.
Okay.
I will search for it in just a minute.
Okay.
Continue.
Honestly,
Okay,
I sent the simple list from past medicine, which has polycythemia vera. Maybe we can wait for Dr. Salma to send from up to date.
باس medicine والله يا دكتور ريان very good because هيديك
Yeah,
الزيت.
To the point.
But
أيوة
for
الزيت
me,
To
بالضبط.
the
yeah,
point.
to target, yes. No need to read
The
more.
oil. Yeah.
أيوة بالضبط.
Exactly. This is what I prefer also to study before the exam. But medicine is the best. Vincent vomiting and dizziness for them. Yes, I think this is for just as a clue. Dr. Ryan was volunteer for this. We have to ask this question also. Other movement in the face and the lips. Okay. Any other question? Dr. Dalia, you have any comments? Dalia Farouk.
دكتور باسم شكرا
Yes.
والله أنا للأسف ما كنت فولي مركزة معاكم لكن كيس صعبة صراحة it's difficult case
Yeah.
but the differential diagnosis or highlight of differential is fair enough I guess
Yeah.
yeah
Thank you.
most probably Dr. Taver did well yeah
Yes. Thank you, Dr. Dalia. Thank you.
Yes, he did great job.
Okay. Thank you, Dr. Tanvir again and Dr. Ayana. Any question, Dr. Ayan, sorry, any question before ending the session?
Thank you all.
Okay. See you tomorrow, inshallah, the communication day. Good luck on the night. Assalamu alaikum wa rahmatullahi wa barakatuh.